Ancient surgery wasn't a desperate, bloody gamble. It was a highly disciplined, often successful calculation. Why would a Neolithic farmer allow a neighbor to scrape a hole into his skull with a piece of flint? How did a Roman legionary survive a deep abdominal repair without the lights going out? And what did it feel like to be the person holding the knife, knowing your patient was feeling every single vibration of the steel against their bone? We tend to view the history of medicine as a slow, dark crawl through a tunnel of agony that only ended when someone finally pulled a mask of ether over a patient's face in the 19th century. But if that were true, how do we explain the thousands of healed bones found in the archaeological record? Why does the evidence suggest that people weren't just surviving these procedures, but living for decades afterward? To understand the reality of ancient surgery, we have to look past the gore and find the hidden systems that made the impossible routine. How is it possible that the oldest surgical procedure we know of, the practice of drilling into the human brain, was also one of the most successful? If you look at the skeletal remains found in Ensisheim, France, dating back to 5000 BC, you find something that defies modern common sense. These are skulls with large, circular holes cut directly into the bone, yet the edges of those holes aren't sharp or jagged. They are smooth. That smoothness is the signature of osteogenesis, bone regrowth. It means the patient didn't just survive the operation, they lived long enough for their body to begin repairing the massive intrusion. If these ancient people were supposedly primitive, why does the data show survival rates that reached as high as 80% in some regions? What did they know about the razor's edge between life and death that we have forgotten? Does a lack of modern chemicals mean there was no such thing as anesthesia? If the razor's edge of the blade was sharp, the ancient knowledge of the earth was often sharper. We have this image of a patient simply biting down on a leather strap, but the reality was far more pharmacological. Why did the Sumerians, as early as 3400 BCE, refer to the opium poppy as the joy plant? It wasn't just for recreation. When you look at the medical papyri of ancient Egypt, such as the Ebers Papyrus from 1550 BC, you see specific instructions for using mixtures of beer, juniper berries, and various plants to dull the senses. But how did they manage the dose? Could they really control the fine line between a patient who is sedated and a patient who stops breathing? This leads us to the soporific sponge, a fascinating piece of medieval medical technology that sounds like science fiction but was a staple of the Salernitan school of medicine in the 12th century. The recipe was a cocktail of nightmare fuel: opium, mandragora, hemlock, and hyoscyamus. Surgeons would soak a sponge in this mixture, let it dry, and then, when it was time for the blade, they would dip it in hot water and have the patient inhale the vapors. Why did this work? Modern toxicology tells us that these plants contain scopolamine and atropine, which induce a state of twilight sleep. It wasn't total unconsciousness, but it was enough to distance the mind from the body. But if the patient was in a daze, how did the surgeon ensure they wouldn't thrash around when the incision began? What did the ancient Indian surgeons know about the human body that allowed them to perform plastic surgery 2,500 years ago? In the text known as the Sushruta Samhita, written around 600 BCE, the physician Sushruta describes a method for reconstructing a nose that had been cut off, a common punishment at the time. This involved taking a flap of skin from the cheek or forehead and grafting it onto the face. How could a patient possibly sit through the rotation of a skin flap without screaming their lungs out? The answer lies in a different kind of preparation. Sushruta didn't just rely on strong wine. He relied on a systematic approach to the razor's edge of psychological preparation. He believed the physician should be like a father to the patient, using ritual and calm to lower the heart rate before the first cut. But even with the best bedside manner, the physical reality remained. If the pain couldn't be fully eliminated, how did they prevent the body from going into fatal shock? Why did the Roman Empire build specialized military hospitals, the valetudinaria, if they didn't have the means to save the men inside? If you visit the ruins of Pompeii, you can see the tools they used: bronze scalpels, bone levers, and triangular elevators that look remarkably like the instruments in a modern surgical tray. The Roman surgeon Aulus Cornelius Celsus, writing in the 1st century CE, described the ideal surgeon as someone who was unmoved by the cries of his patient. This sounds cruel, But was it actually a form of hyperfocus? Celsus argued that the surgeon must have a steady hand that never trembles and a mind that refuses to let the patient's agony dictate the speed of the work. But if the surgeon was focused on his own steadiness, who was watching the clock? The clock, however, was the ultimate enemy, and this is where the history of surgery takes its most dramatic turn toward the razor's edge of speed. If you were a patient in the 18th century, your life didn't depend on the surgeon's knowledge of anatomy as much as it depended on the strength of his forearms and the speed of his wrist. Why was the British surgeon Robert Liston so famous that people would time him with pocket watches? Liston could reportedly amputate a leg in under 2.5 minutes. On one occasion, he was so fast that he accidentally cut off the fingers of his assistant and the coattails of a spectator. How can we call this medicine? Yet, in a world without anesthesia, speed was the only mercy. Every second saved was a second less of trauma, a lower chance of the heart stopping from sheer agony. But if speed was the goal, what happened to the precision? Were these surgeons just hackers and butchers, or was there a hidden artistry in their haste? How did the Inca of Peru achieve survival rates for cranial surgery that were higher than the hospitals of the American Civil War? This is one of the most staggering questions in the history of human health. When archaeologists analyzed over 800 skulls from the Andean highlands, they found a progression of skill that lasted for 1,000 years. In the early days, the survival rate was about 40%. By the time the Inca Empire was at its peak in the 1400s, that number had jumped to nearly 90%. How did they do it without a single drop of ether or a single gram of morphine? They used the coca leaf. By chewing coca or applying it as a paste, they weren't just getting a mild stimulant, they were using a powerful local anesthetic. Cocaine, the active alkaloid in the leaf, numbs the tissue it touches. By combining this local numbing with the razor's edge of a sharpened obsidian blade, which is thinner and sharper than any steel scalpel, the Inca were performing neurosurgery that was virtually bloodless and surprisingly manageable for the patient. But if the Inca had mastered local anesthesia, why didn't that knowledge travel? Why did the rest of the world have to wait until 1846 to find its own answer? Why does the 16th century surgeon Ambrose Pare remain a hero of medicine today if he still worked in the age of agony? Pare was a French military surgeon who realized that the standard treatment for gunshot wounds, pouring boiling oil into the flesh, was actually killing more people than the bullets were. He ran out of oil during a battle and instead used a mixture of egg yolk, oil of roses, and turpentine. He expected his patients to be dead by morning, but instead, they were resting calmly. This was the birth of gentle surgery. Pare's motto was, "I dressed him, God healed him." He realized that if you couldn't stop the pain of the surgery, you could at least stop the pain of the recovery. But if recovery was the focus, how did he handle the moment of the operation itself? He used the razor's edge of the ligature. Instead of cauterizing an amputation with a red-hot iron, he tied off the blood vessels with silk thread. It took longer, and the patient felt every stitch, but it saved them from the secondary trauma of a third-degree burn. Was this a step forward, or just a different kind of endurance test? How did a patient's own brain help them survive the blade? This is the physiological mystery that often goes unmentioned. When the human body is subjected to intense, sudden trauma, it doesn't always just scream. Sometimes, it shuts down. We call it stress-induced analgesia. Why do soldiers on a battlefield sometimes fail to realize they've been hit until the fight is over? The brain floods the system with endogenous opioids, natural painkillers far stronger than anything in a poppy field. Ancient surgeons may not have understood the neurochemistry, but they understood the state of shock. They knew that there was a window of time where the body became somewhat detached from the reality of the injury. Was the goal of the surgeon to work within that window, to finish the repair before the brain's natural defenses wore off? Does our modern horror at the thought of pre-anesthetic surgery miss the point of human resilience? We look back and see a nightmare, but the people living through it saw a necessary, calculated risk. They saw the razor's edge not as a place of terror, but as a place of potential. The patient in ancient Rome who underwent a lithotomy, the removal of a bladder stone, knew exactly what was coming. They had seen others go through it. They had heard the stories. And yet they chose the blade. because the alternative was a slow, agonizing death from infection or obstruction. The surgery was a moment of acute pain exchanged for a lifetime of relief. But how did they handle the psychological trauma that followed? Did the memory of the blade fade, or did it change the way they viewed their own bodies? What happened on October 16, 1846, that changed the nature of being human forever. This was the day of the first successful public demonstration of ether anesthesia at Massachusetts General Hospital. A man named Gilbert Abbott had a tumor removed from his neck while he sat, seemingly asleep, in a velvet chair. When he woke up, he said he felt no pain, only a sensation of scratching. The surgeon, William Morton, turned to the crowd of skeptical doctors and said, "Gentlemen, this is no humbug." It was the end of the age of the scream. But if the scream was gone, did something else go with it? The surgeons of the old world had to be deeply, intimately connected to the patient's physical state. They had to feel the rhythm of their breathing and the tension in their muscles. When the patient went to sleep, they became an object, a machine to be fixed. Did the razor's edge of empathy get duller once the patient was silent? Why do we find evidence of successful couching for cataracts in ancient Greece and India? This procedure involved using a needle to push the clouded lens of the eye down into the vitreous cavity, restoring a blurry form of sight. It sounds horrific, a needle in the eye while you are fully awake. And yet, it was one of the most common and successful surgeries of the ancient world. The razor's edge of the needle had to be placed with submillimeter precision. How did the surgeon keep the patient's eye from moving? They didn't just use drugs. They used the fixation of the other eye. They understood that if the patient focused their good eye on a steady point, the eye being operated on would stay still. This is pure, mechanical understanding of the human body. It shows that ancient surgery wasn't about luck, it was about the clever exploitation of human biology. But if they were this clever, why didn't they find a better way to dull the pain? Was the pain itself a tool for the ancient surgeon? In some medical traditions, the patient's reaction was a diagnostic guide. A scream at a certain point during a procedure told the surgeon exactly which nerve they were near or how deep the instrument had traveled. In the 10th century writings of the Islamic surgeon al-Zahrawi, he describes the use of cautery, burning the skin, to treat various ailments. He notes that the surgeon must be careful to watch the patient's face, for the face does not lie even when the patient tries to be brave. The razor's edge of the fire was a map. But as we move toward the modern era, that map was discarded in favor of total silence. Does the silence of the modern operating room make the surgeon more effective, or just more detached? How did the transition to the soporific sponge in the medieval period change the way surgeons trained? In the universities of Montpellier and Bologna, the study of surgery began to merge with the study of medicine. For the first time, the people holding the knives were the same people reading the ancient Greek and Arabic texts. They began to experiment with the razor's edge of chemistry. They realized that different plants worked better for different people. They began to understand that a small child needed a different dose than a grown man. This was the beginning of anesthesiology, hundreds of years before the word was even invented. But the dosage was still a gamble. If the sponge was too wet, the patient died. If it was too dry, they woke up mid-sawing. Why did it take so long to standardize these mixtures? Why was it so hard to turn a holy sponge into a reliable science? The answer might lie in the way ancient people viewed the relationship between the mind and the body. To a modern person, pain is an error code, something to be deleted. To an ancient person, pain was often seen as an intrinsic part of the healing process. In many cultures, the fire of the pain was thought to burn out the cold of the disease. The razor's edge wasn't just a physical boundary, it was a spiritual one. When we look at the history of surgery, we aren't just looking at the history of tools and techniques. We are looking at the history of how much a human being can endure. And the evidence is overwhelming. We can endure almost anything if the goal is survival. Why do we find trepan skulls in the archaeological record that show evidence of 5 or even 6 separate operations on the same person? This is perhaps the most incredible fact of all. It's one thing to survive a single hole in the head. It's quite another to go back for a second, a third, and a fourth. Does this mean the surgery was addictive? Or does it mean it was so effective at relieving the pressure of headaches or epilepsy that the patient willingly chose the razor's edge of the flint knife over the agony of their condition? It suggests a level of trust between patient and practitioner that we rarely acknowledge. It suggests that pre-anesthesia surgery wasn't a chamber of horrors, but a place of profound hope. What if the most important surgical tool wasn't the knife or the sponge, but the human voice? In almost every ancient medical text, there is a mention of the assistant. Their job wasn't just to hold the patient down, it was to talk to them. They were the ones who held the patient's hand, who whispered encouragement, who kept their mind anchored in the room while the body was being invaded. This, vocal anesthesia, is still used today in minor procedures where the patient is awake. It reminds us that the razor's edge of human connection is often just as powerful as the razor's edge of the blade. The surgeon worked the flesh, but the assistant worked the soul. If we go back to the Roman battlefields, we see the true scale of this ancient discipline. A Roman surgeon on a campaign might have to treat 100 men in a single day. He didn't have time for sponges or wine. He had to rely on the razor's edge of his own training and the sheer resilience of the soldiers. He used vinegar to wash the wounds, a practice that we now know killed bacteria, even if the Romans called them seeds of disease. He used bandages made of clean linen. He worked with a speed that we would find terrifying but which saved thousands of lives. Why do we assume they were failing just because they were suffering? The success of an empire was built on the ability of its doctors to repair its warriors without the luxury of sleep. How did the discovery of the ligature by Ambrose Pare in the 1500s change the survival rates of amputations? Before the ligature, the only way to stop someone from bleeding to death after losing a limb was to press a red-hot iron against the stump. This caused a massive, agonizing burn that often led to infection and death weeks later. Pare's decision to use a needle and thread to tie off individual arteries was a revolution. It was the razor's edge of precision replacing the blunt force of fire. It allowed the body to heal naturally. But it required the surgeon to be calm enough to find a tiny, pulsing vessel in a sea of blood while the patient was screaming. How do you find that kind of focus? Where does a person find the internal silence to do such delicate work in such a loud environment? Does the history of ancient surgery teach us that we are soft compared to our ancestors? Not necessarily. It teaches us that we are adaptable. We have built a world where pain is optional, and so we have lost the mental calluses that our ancestors carried. But the biology remains the same. If the lights went out tomorrow and the chemicals ran dry, the razor's edge would still be there, waiting. The flint would still be sharp. The poppy would still bloom. And the human brain would still find a way to shut the door on the pain long enough for the work to be done. We are the descendants of the survivors, the ones who stayed on the table and refused to die. Why do we still use the term operating theater? It's a carryover from the days when surgery was a public performance, a place where students and spectators watched the razor's edge in action. It was a place of high drama because the stakes were life and death, visible to everyone in the room. There was no hiding behind monitors or sterile drapes. It was one person, one knife, and one goal. When we think about the horror of the past, we should also think about the bravery of the past. It took a special kind of courage to be a surgeon, and an even greater kind to be a patient. If the razor's edge of the blade is the symbol of our struggle against death, then the history of surgery is the story of how we sharpen that edge year after year, century after century. From the flint scrapers of the Neolithic to the silk threads of the Renaissance, we have always been looking for a way to fix what is broken. We have used the earth, we have used the clock, and we have used the sheer force of our own wills. The pain was the price, but the price was worth paying. We often imagine the pre-anesthetic era as a time of 100% mortality, a dark age where stepping into a surgeon's room was a death sentence. But the more we dig into the actual records, the more that assumption falls apart under the weight of the data. When we look at the 800 skulls recovered from the Incan heartland, we find that by the year 1400 CE, the survival rate for trepanation wasn't just good, for its time, it was 91%. That is a higher survival rate than most major surgeries in the 1860s during the American Civil War. Nearly 450 years later, where infection and slow technique turned field hospitals into morgues. Our ancestors weren't bumbling in the dark, they were masters of a high-stakes discipline that we are only now beginning to truly respect. The next time you see a surgeon, remember that they are the heirs to a 10,000-year-old tradition of the razor's edge, a tradition that proved human skill could conquer agony long before the world ever learned how to sleep through it. If you found this dive into the forgotten history of our resilience fascinating, consider joining our community of curious minds. There are thousands of stories like this waiting to be uncovered, and we'd love to have you for the next one. What's one medical myth you've always wondered about? Let me know in the comments.